I would like to welcome our esteemed guests here, Professor Donfield, Professor Dua, Dr. Majid Al-Kharashi, and I would like to thank them for being amongst us. I would like also to appreciate the sponsorship of our colleagues here, and I'd like to welcome our first speaker tonight, Dr. Donfield. Dr. Donfield, I think I'll just introduce him briefly as a trustee of medical school and clinical professor of ophthalmology at New York University. He's been a president and a chair of multiple organizations, and he had contributed tremendously in multiple publications and research. I would like to welcome him to speak to us about the past, the present, and the future of dry eye. Please, Dr. Donfield.
Very good. Well, thank you for that introduction, Dr. El-Saadi. I'm very honored to be speaking here today, especially with such notable doctors who will be speaking with me. I think it'll be a very interesting symposium, and I hope that all of you who are attending today enjoy it as much as I know I will. I'm going to give you my approach to treating dry eye, and I'm going to start with a little bit of a background of what dry eye is, then how common it is, and then we'll talk about current treatments and then future currents that are being developed going forward. I do consult with a number of companies that I'll be speaking about today, but I don't think that'll change what I'm going to say. So you're going to hear a little bit later about the importance of surgery and the ocular surface, but I would just start by saying that I think we all agree that the tear film is the most important refractive surface of the eye, and as a matter of fact, vision starts at the tear film. Without a quality tear film, all the recent advances in technology are lost. So if we're doing excimer lasers, or we're doing femtosecond lasers, or we're doing multifocal IOLs, all these wonderful technologies that I've embraced in my practice, and I'm sure you have embraced as well, are lost. So that the dry eye is the common thread that joins all of us together in improving visual outcomes. The ocular surface is the rate-limiting step for surgical outcomes. It affects IOL calculations. It affects topographic and wavefront excimer ablations, postoperative healing, and quality of vision and patient satisfaction. Here's an example of a topography. This is a patient who came in for cataract surgery and had an irregular surface. The topography is a very important parameter in looking at patients with dry eye. And when you see this type of irregular surface, no dropout per se, but just irregular, think dry eye. And you can see that the IOL calculation is calling for a 19.5 diopter lens. After treatment for dry eye, you can see that the topography is much more regular, and now it's calling for a 21 diopter, actually, intraocular lens, and it also would recommend a toric lens, which I would not have placed based on the previous readings. Disruption of the ocular surface further distorts the distortion associated with multifocal IOLs. So if you're using presbyopic IOLs in your practice, even minor dry eye will cause a significant loss of quality of vision in these patients. So let's ask the next question of what is dry eye? Dry eye is extremely common. It can negatively impact quality of vision. It can cause fluctuation. Quality of life can be greatly impacted. As a matter of fact, a paper that was published by Schiffman a few years back showed that patients reported a willingness to trade years at the end of their life to be free of dry eye disease. So dry eye is a serious problem that we as ophthalmologists may sometimes not really appreciate. A healthy tear film is a delicate balance of lipid, aqueous, and mucin, all together with over 100 different proteins. So when we place an artificial tear in the eye, that has basically just a few chemicals and minimal proteins, if any at all, we're really not replacing the tear film. The tear film is a delicate balance of cytokines and proteins and growth factors, etc. The tear film has, again, three components, starting at the lipid. Lipid, it comes from the meibomian glands, and it's very important to evaluate the meibomian glands. The lipid layer prevents evaporation. Then that's followed by the aqueous. Aqueous comes from the main and accessory lacrimal glands, and secretions converge in the excretory ducts and then to the ocular surface. In dry eye, inflammation, mostly T lymphocytes, will fibrose and damage these acinar structures. And then finally, there's mucin, which is 5 to 20% of conjunctival epithelial cells. They produce substances that increase the viscosity of the normal tear film and prevent dry spots. The pathophysiology of dry eye involves the lacrimal glands having T-cell interaction causing chronic irritation, which causes cytokine release. There's a damage to the nerve, so many times patients with dry eye will have corneal anesthesia. The lack of corneal sensation reduces the feedback loop to the midbrain, so there's less innervation causing secretion of tears. In chronic dry eye, there's lesser concentrations of proteins, less growth factors, less mucin. Cytokine balance is shifted from an anti-inflammatory to a pro-inflammatory, and proteases are activated. And abnormal tear film is the hallmark of dry eye disease. So let's move on to now the prevalence of dry eye disease. Various studies have been performed that look at the prevalence, and these numbers are probably on the lower side. But it's been suggested that approximately 15% of patients who have 15% of patients have dry eye, and we know that it's very highly associated with gender and age. That the women have a dry eye about 2 to 3 times more commonly than men, and it increases associated with age group as well. So again, with dry eye, it's seen in all patient populations, but it's more common certainly in women. In the United States, it's suggested that 1 out of every 7 American adults has dry eye disease, and it is considered the single most common disease of the eye in the United States. And there are multiple risk factors for dry eye. We know that age and female gender, as I've already mentioned, are a risk factor, but so is diet. Autoimmune diseases such as thyroid disease or lupus or rheumatoid arthritis predominantly. Medications and occupational and environmental changes will also cause dry eye disease. Dry eye deserves our attention because it's the most common complaint coming to our offices. It certainly impacts on patients' quality of vision. It's also been shown to reduce work productivity, the ability to use technology, and decreases reading speed. And the most important concept for me is that dry eye is chronic and is usually progressive. So no one starts out with level 3 or level 4 dry eye disease. People start out with level 1 disease and it progresses. It's been very highly suggested that if you can stop the progression of dry eye disease, you can limit the severity of the disease as patients age. It's also felt that dry eye is underdiagnosed. Possibly 55 million Americans have dry eye, and 39 million of them have not been diagnosed. Dry eye is generally considered to be an easy diagnosis to make, and I would argue very strongly that it's not. Dry eye is a very difficult diagnosis to make because the symptoms can be so disruptive and so variable. Some people complain of itching, some people complain of dry eye, others complain of watery eyes. For me, one of the hallmark symptoms, and I have a favorite symptom, is blurred or fluctuating vision. This is particularly important in the setting of surgery. Any patient who complains that the vision fluctuates between blinks or during the course of the day or after computer use for a certain amount of time has dry eye, until proven otherwise. So how do I make the diagnosis of dry eye? Well, the first thing of all is to ask the patient. We have a questionnaire for all patients who come to our practice. There are a variety of good ones. There's the speed questionnaire, the OSDI, or you can modify your own like we have in our practice. And ask the patient. Any patient who comes in who fills out these forms, who the technician evaluates and says this patient most likely has dry eye, that empowers our technician to order dry eye testing so that I can have the testing in front of me when I examine the patient. The conventional diagnosis of dry eye involves a series of different tests. No one test is sufficient, but they're helpful. I happen to like lissamine green very much, as well as rose bengal. Lissamine green will stay in the conjunctiva where fluorescein will not. By the time someone has fluorescein corneal staining, usually the dry eye is fairly significant. The Schirmer test we'll talk about later on, but this is one of the oldest tests going back to 1904, and a test that I really don't perform that often unless I'm looking for patients who have Schirmers of 0 or 1 and I want to establish Sjogren's syndrome. I look at tear meniscus, I look at the lids, I look at tear breakup time, and then sometimes I'll check corneal sensation as well. Diagnostic dyes play a significant role, and here you can see classic corneal staining as well as rose bengal, and lissamine green staining would look almost the same, only different color. Tear breakup, we all know, is a very common test with fluorescein, and it varies, but again, anything under 6 seconds is considered distinctly abnormal. Schirmer test is done either with or without anesthesia. There's no right answer as to whether you should do either way, and I, again, very rarely do Schirmer tests as I find it to be a very poor test. And here's a picture of Frederick Schirmer in 1904 when he invented the Schirmer test. And here you can see what cataract surgery looked like in 1904 as compared to a car and to a telephone. Very little has changed with Schirmer tests. In 1985, when I did my fellowship with Dr. Leibson, which is where Dr. Dua also did his fellowship, you can see that cataract surgery was still fairly archaic, using cryoprobes. The car, the telephone, the IOLs were all fairly old. And now in 2020, we've moved on to many new technologies. And I'm very happy that in dry eye, we have new technologies for diagnosing dry eye, like osmolarity and MMP-9 testing, with many more tests coming shortly. I just want to mention very quickly 2 tests that I believe in, that is tear osmolarity. Tear osmolarity has been considered to be the most accurate way of diagnosing dry eye. If you only had one test, this is the one test that I would choose, but it adds on to the other tests I have. It's considered abnormal if the osmolarity in one of the eyes is greater than 314. I take it back, greater than 308. Here, where you see one eye is 314, one eye is 290, this is distinctly abnormal for 2 reasons. Over 308 is abnormal, and also a difference between the 2 eyes of greater than 8 milliosmoles is also a hallmark, as patients lose their ability to control homeostasis. So differences between the 2 eyes in over 308, osmolarity is considered the best biomarker. MMP-9 testing is also used to initiate anti-inflammatory therapy. This is helpful when you want to consider using anti-inflammatory therapy. There is a qualitative test now, but a quantitative test for MMP-9 is coming, which has high sensitivity for diagnosing inflammatory dry eye disease. I like point-of-care testing in that it empowers my staff to perform the test before they see me. It permits me to institute proper management and allows more time for me to talk to the patient about treatment. I spend less time diagnosing dry and more time treating it. So let's talk about a dry eye treatment plan. Treatment involves several different steps that I've listed here. There's topical therapy, which is a mainstay, systemic, surgical, nutritional, medication on the level of severity, level 1 starting with tears and education, and then moving on to anti-inflammatory therapy. Shirts I rarely use as a blur vision, but for some patients it's a great thing. And serum tears, taking the patient's blood, spitting it down, And leaving the plasma is a wonderful treatment for very aggressive dry eyes. It replaces many of the proteins that are lost in patients with dry eye. So inflammation has been shown to be the key component to dry eye disease. It's a continuous cycle of inflammation. The more inflammation they have, the more stress there is to the ocular surface, which produces poor quality tears and tear film instability. It's a primary effect, is the effect of dry eye and inflammation. I want to present our experience with lifitegrast, which is a novel medication for the treatment of dry eye. I was the first author in the FDA trials, and here you see the study that went to the FDA for approval of lifitegrast in the United States. Lifitegrast is an LFA1 antagonist, which is a new class of drugs. It's anti-inflammatory. And essentially the effect of lifitegrast is very simply shown in these pictures. Here you see a T lymphocyte, which is the inflammatory cause of dry eye, adhering to the ocular surface below. The adherence to the ocular surface occurs when the LFA, or the lymphocyte function-associated antigen, adheres to ICAM, intracellular adhesion molecule. That binding, which is like Velcro, allows the T lymphocyte to adhere to the ocular surface. Without this adhesion, T lymphocytes will not adhere to the ocular surface and will not have an effect on dry eye. ICAM binding to LFA1, these are words you don't really need to remember, but essentially they prevent T cell migration, T cell activation, and prevent cytokine release. Lifitegrast is a molecule that binds to the target tissue, preventing adhesion. And here you can see lifitegrast, which is an LFA1 antagonist, binding to the LFA1 site, which prevents the ability of the T lymphocyte to adhere to the ocular surface. Because it acts immediately, the effect of lifitegrast is almost immediate on patients who receive this drug compared to other anti-inflammatory therapies. In the FDA trials, we looked at over 2,400 patients, and we evaluated them at 4 12-week trials and 1 1-year safety trials. In all 4 of the studies, lifitegrast showed relief of eye dryness at week 6 and 12, and eye drops were reduced in 2 out of the 4 studies as soon as 2 weeks after therapy. Adverse reactions were mild. Some patients have a little bit of burning. I find that when they do have burning, adding a topical corticosteroid plays a significant role in improving the patient's symptoms. In the FDA trial, they complained of dysgeusia or a bad taste in the mouth. In my experience, this has been a mild problem, and really haven't seen it that often. But again, most of these symptoms are mild, and very rarely will a patient complain enough to discontinue the medication. Here's a look at the eye dryness scores, seeing that in the studies which were evaluated at baseline, 2 weeks, 6 weeks, and 12 weeks, patients had a very dramatic improvement with lifitegrast at week 12, but also a significant improvement at week 6. And even at week 2, and studies 3 and 4, there was a significant improvement in eye dryness as soon as 2 weeks after therapy. This compares to the FDA trials on cyclosporin, where actually symptoms were worsened for 6 weeks, and only at 3 months did the patient start improving, which is one of the major differences between these anti-inflammatory therapies, is that the lifitegrast works much more rapidly. Responder analysis, which we just recently published, showed a very high response with a 70% improvement at day 84, and a high response rate as early as 14 days. So this is the kind of the mainstay of aqueous deficiency dry eye for me in the United States, but there are a variety of other medications that have been approved in the United States that I just want to go through very quickly. And that is, cyclosporin is now available as a multi-dose, preservative-free, which is easier than the unit dose for many patients. There's also a nanomicellar compound of cyclosporin from sun. Neurostimulation has been used, placing these neural probes in the nose to create a loop to improve dry eye, has been shown to rapidly improve tear film quality. For patients with very severe dry eye, I like using amniotic membranes. Once the epithelium is broken down with dry eye, it's hard to restore it, so amniotic membranes play a significant role in reducing inflammation and promoting healing. And sometimes for patients with very severe dry eye, these amniotic membranes really can be a lifesaver. And here you see them sitting on the eye. Serum tears, as I mentioned before, are very helpful for patients with advanced dry eye. We simply remove the clotted blood and just replace it with a serum that contains proteins. Senogermin or Oxervate is a neurotrophic keratitis drug for people who have neurotrophic keratitis associated with dry eye. This is a biologic, recently approved in the United States as well, which is helpful for severe dry eye. And there's a pipeline of medications that are available, that are coming, that are exciting. And I think dry eye is one of the most active areas of research, and we're participating in many of these studies here in the United States. Kala just had their mucus-penetrating loteprednol approved, which is the most recent pipeline topical. Biologics are very exciting, and one that I'm really looking forward to is one called Lubricin, which is a human glycoprotein from Novartis. It is a recombinant endogenous glycoprotein, which has anti-inflammatory, anti-adhesive properties, and has been shown to improve the signs and symptoms of dry eye, and the FDA trials are now ongoing. Pipeline devices include BAK filters, dexamethasone non-preserved punctal plugs, and cyclosporin punctal plug drug delivery. Skip through that. And I'll just finish by just presenting two quick cases of how I manage dry eye myself. A 72-year-old male, a little hyperopic, wants surgery as soon as possible. History is unremarkable, wants to get rid of his glasses. Does not complain of dry eye, but admits to visual fluctuation, admits to light sensitivity and watering eyes, so it sounds like he has dry eye. When I look at this topography, the topography is just a little bit irregular on his presentation. We did an osmolarity, which was high. MMP-9 was positive. Corneal staining was moderate. Tear breakup time was short. And his meibomian glands were also clogged. So he had aqueous deficiency and meibomian gland disease. We treated him with lifitegrast 5% twice a day, loteprednol 0.5% 4 times a day, oral omega-3s. We use a thermal pulsation device called LipiFlow, high-quality tears, and waited 2 weeks. We saw the patient back. Topography was regular, and the patient had very uneventful surgery. Along a similar line, here's a patient who's 74 years old who came to see me complaining of having had a presbyopic IOL that was not working well. The patient was very upset with quality vision, glare, and halo at night. And the question I would ask the audience is, what would you do for a patient who complained of quality of vision? Would you change the lens, implant another lens in the other eye, do ocular surface disease testing, or a limbal relaxing incision? And the answer should always be, any patient who has any visual symptoms after cataract surgery should always have ocular surface testing done first. That's the most important thing to resolve. And this patient, again, had dry eye, classic findings of an elevated MMP-9 and osmolarity. And this is a patient's topography showing marked irregularity. This patient could possibly do well with a presbyopic IOL. The patient was treated with tears, lifitegrast twice a day, and oral omega-3s. Symptoms resolved. The patient kept the lens and ended up doing well. So treating the dry eye in this patient allowed me to not have to do an IOL exchange. In conclusion, dry eye disease is underdiagnosed and undertreated by most eye care professionals. It affects cataract and refractive surgery. It has a significant effect on morbidity with decreased vision and reduced quality of life. And recent improvements, as well as some surgical therapies, will greatly enhance our ability to manage dry eye in the future. And with that, I conclude my presentation, and I thank you very much for your attention.
Thank you very much, Dr. Donfield, for this elaborative talk about dry eye. I'd like just to inform the audience that we'll be taking all the comments and questions toward the end of the talks. And it gives me now the pleasure to introduce Professor Dua. Professor Dua is a professor of ophthalmology at University of Nottingham. He has contributed towards peer-reviewed articles, multiple publications. He was an author and co-author he was a co-author in the British Journal of Ophthalmology, and in appreciation to his great service to the eye healthcare, health education, he was honored by the Queen of Queen Elizabeth, the title of Commander of the Order of British Empire in the year 2019. Professor Dua, please, it's a pleasure to have you, and I will just give you the podium to give us your talk about ocular surface reconstruction and limbal stem cell deficiency. Please, Professor Dua.
Well, thank you very much, Ahmed, for your kind invitation and your kind introduction, and to Eric for his wonderful presentation on dry eye. I learned a few things there. I'm going to take you through ocular surface reconstruction with some modern thoughts on how we do this. My list of declaration is nowhere near as long as Eric's, but these are the ones. So when we look at anybody with dry eye, I'm saying with anybody with limbal stem cell deficiency, the first thing you have to do is establish the diagnosis. So look at the amount of corneal and conjunctival involvement, look at the inflammation, whether it's active or quiet, and the disease that caused it. Now, if you look at the disease in terms of scarring, So we look at the disease in terms of scarring. We look at whether chemical burns are non-progressive scarring. After a few months it stops, whereas the progressive scarring is like Steven Johnson and the OCP. We evaluate the extent of the deficiency. Is it partial or total, unilateral or bilateral, and whether the visual axis is involved or not. The slides are moving on their own. So anyway, and then you evaluate the eye and the patient. You look at everything, the eyelids, the tear function, the pressure, the cataract, because it's very important that we deal with all the other problems if they exist before we start to deal with the limbal reconstruction. And also, it's always better to operate on a quiet eye when all inflammation is under control. If we have a partial limbal stem cell deficiency, then the algorithm is you do examination to see what is the extent of the conjunctivalized area. If the visual axis is not involved, you can leave it alone or give some lubrication to treat the symptoms. If the visual axis is involved, then the treatment of choice is the sequential sector conjunctival epitheliectomy, and if there's a fibrovascular pannus on the cornea, then we do a sector limbal transplant. And the amniotic membrane may be used with any of these. So let's take a look at some of the basic principles that underlying ocular surface healing and therefore the principles of reconstruction. If you get a large corneal epithelial defect with an intact limbus, then it does not heal by forming circles of diminishing diameter, but from the remaining intact epithelium, which is this sheet here, the circumferential intact epithelium of the limbus, you get convex sheets migrating centripetally. They meet each other to make geometric shapes, which then meet each other to form these Y-shaped contact lines, much like the Y-shaped lines of a lens that we see inside the lens, the sutures, which are also points of meeting of epithelial sheets. And bits of the Y can be missing to give you this pseudodendritic appearance. And here's an example. This is a convex sheet, and here's another one starting. Here you get this quadrilateral shape, and eventually you can see over there this little healing pseudodendrite, which is highlighted with fluorescein stain. But often this is what happens where the limbus is also involved, and when the limbus is also involved, then it follows a very different pattern, which we call rule number 2. From the remaining intact epithelium, tongue-shaped projections appear at either end. They migrate circumferentially till they meet. And once they meet, it then becomes like a cornea with an abrasion with an intact limbus. And it follows the same set of rules as rule 1. So here you can see from this remaining corneal epithelium over here, these tongue-shaped sheets are progressing. They will migrate circumferentially till they meet. Then cornea heals with corneal epithelium, conjunctiva with conjunctival epithelium, and normality is restored. But sometimes rule 3 happens, and this is where we start getting into the realms of stem cell deficiency. Before these circumferential migrating sheets can meet, the conjunctiva crosses over, and a variable area of the cornea is covered with conjunctival epithelium. This epithelium is thin, it's irregular, it shows late fluorescein staining, attracts blood vessels, and is prone to erosions. Conjunctivalization of the cornea is the hallmark of limbal stem cell deficiency. As you can see over here, this is a condition we've called columnar keratopathy, columns of conjunctival epithelium alternating with normal corneal epithelium. All of these show late staining. Here you can see this very large area of conjunctivalized epithelium with late staining above and below, and this surviving strip of corneal epithelium and bits on either side. And again over here, you're clear to see corneal epithelium and the large area of conjunctival epithelium covering the visual axis. One thing to note, as you will see in all these pictures, is these tiny little undulations of the corneal epithelium at the junction of the two phenotypes. That's a classic giveaway to tell you that this is what is happening here. You're getting this abnormal metaplastic conjunctival epithelium that is growing onto the cornea. Now, if you see that happening, like in this patient over here, following a chemical burn, the conjunctiva is coming in, you can actually scrape it away at that point, not let it cross until this sheet from here has migrated circumferentially and covered the whole cornea. Even if it has crossed and you see it at this stage, you can still scrape it away and allow the cornea to be repopulated by cells coming from the intact limbus. Because if you don't, then often this is how it will end up, and this is how this eye ended up. You can see conjunctivalized area attracting blood vessels, some deep vessels over there, and an area over here of limbal stem cell deficiency, which can cause chronic inflammation and scarring. So that's what you can avoid right in the early stages if you're watching the patient who's presented early after an injury. Another principle very important to bear in mind and is coming into play more and more in modern ocular surface reconstruction is this concept of central islands. This is a paper we published, I think, here way back in ophthalmology in 2000. And what you can see is that here's a sheet of corneal epithelium in the presence of a completely destroyed or disturbed limbus. And this is very common in aniridia. So here's a sheet of intact corneal epithelium and late staining all around it. Another one over here, another one over here. You can see this one here, this one. All these are what we call central islands of surviving epithelium. And particularly in aniridia, these islands can survive for 10, 12, 14 years or more in the absence of a limbus. And that we've done in 1 or 2 cases by impression cytology, others by confocal microscopy. We've shown that the limbus is gone. So what it tells us is that the central island, the basal epithelium, which are the transient amplifying cells, have the ability to sustain physiological turnover of the central epithelium for a long period of time. But in the presence of an injury to this area, then you need limbus. But because there is no limbus, then you end up in problems. So the limbus actually plays an important role in the wound healing response to injury, but in normal physiological turnover, maybe its role is very minimal, and there's a lot of evidence to support that. And here you can see by confocal microscopy, if you see cystic spaces, you see goblet cells, you see hyperreflective epithelium, which is always the conjunctivalized metaplastic epithelium as against the normal epithelium. All these are features of conjunctivalization of the cornea and limbal stem cell deficiency. So how will we treat this patient where they have already presented with this conjunctivalized metaplastic epithelium? This is partial stem cell deficiency. We do the scraping, which is also called sequential sector conjunctival epitheliectomy. You scrape away all the abnormal epithelium, get the edges to freshen a bit, and let the surface heal from cells coming from here in that direction towards the pupil. While they're coming in, the conjunctiva will also grow back in, so you can scrape it away if you like, or do that on a couple of occasions every day, every other day, topical anesthesia on the slit lamp, till you have moved the junction of the two phenotypes way across the visual axis. And when it does that, then you will find within a matter of days, visual acuity is restored to normal, as we've heard, because the corneal epithelium comes to normal and the tear film comes back to normal over it, and there's a dramatic improvement in vision. And here's another example of the patient I showed you. The same thing has been done, SSCE. You can look at that cornea, now look at this cornea, and that cornea, and look at this without the fluorescein, absolutely pristine. A simple technique, and you can use a sharp instrument, a blunt instrument, a dry swab, anything, because this epithelium is quite loose and will brush away easily. Then another concept I want to introduce here is that of autologous conjunctival grafts. So there are patients where you can see this patient has got extremely severe burn, complete marbleization of 270 degrees of the surface of the eye, and the cornea is completely denuded. We tried an amniotic membrane to give some relief, but it retracted, it melted off, and nothing happened. So out of desperation, we took a free patch of conjunctiva from the other eye, and you stitch it to the surface such that the edges are stitched to places where there are blood vessels. So it's like a tenoplasty. You know, if it's deep down, you can stitch it there and extend the conjunctiva up. When that happens, you will get a reperfusion injury in a day or two. It looks quite grotesque, but what happens is, I don't know why my slides are moving forward on their own, but there you are. So when it all settles, it becomes normal like this. And at this point, you can see what, according to the Roper-Hall classification, would have been an eye that is in the bucket. But according to the new chemical classification we introduced many years ago, even if there's a bit of conjunctiva surviving, you can salvage the eye. So you can see this eye now all quiet. You take away the conjunctiva from here. You use it to reconstruct a symblepharon. You do an autolimbal transplant, as I've shown over here. You can see the suture is still there. When that's settled, it becomes like this. And that marbleization, all that is now vascularized. And you've got this patient with a rigid gas permeable contact lens with a 6/9 vision. So stepwise approach gives a lot of benefit here. Again, very severe non-healing epithelial defect from a chemical burn. We put this conjunctival autograft. Immediately you see the vasodilation, the hemorrhage, and all due to reperfusion injury. Everything settles and the eye becomes very quiet, ready for further procedures. Now, when you have total stem cell deficiency, you can do in vivo expansion or ex vivo expansion. In vivo, you have the autolimbal transplant, the simple limbal epithelial transplant, and the allolimbal transplant, which you can get from a living relative or a cadaver. An ex vivo expansion of limbal cells, conjunctival cells, oral mucosal cells, which can be grown on amnion, on collagen, on fibrin, other substrates. But the only licensed product is Ocular, and I'll touch on that in a slide a little later. So the concepts here are you do a niche transplant or a no niche transplant. So in autolimbal, allolimbal transplantations, you're actually taking a part of the limbus and putting it on the other side. That is the niche coming with the limbal stem cells. But in ex vivo expanded sheets, there is no niche. You're just populating the surface, the substrate, which is here fibrin, or it could be amnion like in SLET, and you are putting cells there which are rich in stem cells, but they're not at the limbus. And that is what we would call a no-niche transplant. Now, this is an example of a niche transplant, so quite metaplastic epithelium. Here are the two explants from the other side. Cells have started growing from the explants, and over time you can see that whole cornea gets re-epithelialized, and that's how it looks post-operatively. Here's another example, an iridia of a niche transplant from the mother to the daughter. So that's the surface pre-op. That's the explant on the top. There was one at the bottom. And then these cells from the explants will go exactly in the rule 2, like I showed you, circumferentially till they meet. Here they've met. Then they will move in, and then it will go back to normal. And here now it's normal, but all that white is the cataract. You do a cataract and put an iridia lens implant, and you can restore normality in that patient. The non-niche transplants are the slit, where you take a tiny piece from the limbus and you cut it into multiple pieces, and over an amniotic membrane you glue it and put a contact lens on top. This is from wherein the Sang-Wan's developments. Some of these pieces have only fibrous tissues, some of them have epithelial cells, some of them have stem cells, so it's variable. But the cells do grow from that and they populate the whole surface. Here you see a patient that underwent the Ocular. Like I said, that's the only licensed stem cell product in the world so far, and it uses a biopsy just like this one to expand the sheet ex vivo and then transplant it. You take away the fibrovascular pannus and you transplant it on the surface, and you can see you get a pretty good outcome. But the question that is unanswered is that what happens to this or to this if there's an injury in the middle? Where is the limbal drive or the niche from which new cells will populate the center? Because these are akin, both these are akin to central islands. And when there is no limbus and there's injury, and anecdotal evidence from colleagues tells us, and we've had one patient where there's injury and this whole thing gets reconjunctivalized and the stem cell deficiency comes back. Now you can imagine this Ocular costs a massive amount of money, 85,000 euros for one transplant. And if you go and lose it because there's no niche, it's a sad state. But those are things to bear in mind when we look at all these modern therapies that are coming along. Now, the last bit I want to cover is about controlling the conjunctiva. Now, here is a chemical burn with the large non-healing epithelial defect, fibrovascular pannus, classic features of stem cell deficiency. The standard treatment, 360-degree peritomy, peel off the conjunctiva, bring the two limbal pieces from the other side. And here note that it is the 3 millimeters of conjunctiva, 2 clock hours, the limbus, and a little bit less than a millimeter, about half to 0.7 millimeters of peripheral cornea. Very important, that concept of bringing the peripheral cornea. But let's leave that for the moment. Now what's happening is here, from these explants, the cells have started to grow in, as you see above and below, but the conjunctiva is also growing in on both sides. Now, if the conjunctiva grows in, you've got a mixture of corneal epithelial limbal-derived cells and conjunctival cells, and you have a problem. So you have to scrape this away. So what you do is SSCE. From one edge of the explant to the other, you take away all the conjunctiva every day, every other day, so that it does not cover the surface, and the surface is covered only from cells coming from the limbal explants. So that's what we do here. We scrape all that away, and true to form, they will migrate circumferentially. So here they have met, as you can see. These ones are about to meet. The conjunctiva is away. Now they have met. The conjunctiva will not go beyond that due to contact inhibition. This whole surface gets resurfaced from the limbal explant-derived cells, and you can see how nice the cornea becomes with that large chemical burn that the patient had before, as you see here. And here are the little explants that are bedded in to this cornea. So this patient didn't even need a cornea transplant. So if you follow those principles, remember those rules, and then use them to your advantage, you can get very good outcomes. But this SSCE following limbal transplantation causes some bleeding. It makes the patient wanting to come back. Patient has to come back repeatedly, and sometimes causes discomfort. So we made an innovation of our own technique, which you see here. If this is the affected eye, this is the unaffected eye. Do your peritomy, take the fibrovascular pannus away. If the substrate is abnormal, then what we do is we put an amniotic membrane inside, and we brought the two explants. The top part is sutured to the conjunctiva, and there's one suture here, one here, and one across, as is illustrated over here. Then what we do with this third step, which is very important, is the final, that you take an amniotic membrane and you put it to cover all of this, but tuck the amniotic membrane, the dotted line, underneath the edge of the conjunctiva. So any conjunctival epithelium will be forced to grow on the amniotic membrane. That's why it's called amnion-assisted conjunctival epithelial redirection, or ACER. So when these cells are growing on the top, the explant-derived cells are growing underneath. You may not have an amniotic membrane inside, like I've said, but in some cases we do put it, and that gets covered with epithelium derived from the explants. You leave it like that. In anything between 2 to 4 weeks, the outer membrane either falls off or you can take it off. And then you will find that the two kinds of epithelia are completely segregated from each other, and you get very nice wound healing. So here's one example without fluorescein, with fluorescein, and this is one of the very first few patients we've done. So you can see there's an amniotic membrane inside and there's this acer membrane outside. And because you tuck it in, except where the explants expand to suture to the conjunctiva, so that bit hangs loose above and below. And then you can see here, the conjunctival cells are growing on the outer membrane, and here they're growing on the outer membrane, but 4 weeks, the outer membrane has come off. So we just snip it off from here with the Vanna scissor on the slit lamp, and you can see how nicely the underlying membrane is covered with epithelial cells from the surface, from the upper and lower explants. And here's one high power, and this patient actually did need a deep lamellar keratoplasty after all that was settled. But this is a classic example and one of my best examples. This patient, going back 10 years or 15 years ago, was told he needs an exenteration because of diffuse ocular surface papilloma. So we treated this with mitomycin, we treated this with cimetidine orally, we gave interferon alpha, and finally it settled to this stage. In between, a biopsy was done which showed corneal intraepithelial neoplasia. So he had CIN arising from this diffuse papilloma. Once thing was all settled and we had a year of quiescence without any progression, we then went and did this. We did this acer technique. So we took the explants from the other eye, and here we've used a vacuum-derived membrane called Omnigen. I have to declare my interest here, as I've done in the beginning, that I'm involved with this company and hold a patent on the drying method. So what you see here is that Omnigen, on the other advantage of this is that it's very transparent and you can see what's happening through it on the surface of the cornea. So here's the fluorescein stain picture of that day one. These are the two explants, and the wrinkles are in the Omnigen, but you can see the cornea through it, and there's no cells yet. But then you can see that the cells have started to grow. You can see that sheet over here, which you can see right through have come from this explant, and there's a sheet over there that is growing from the upper explant. So cutting a long story short, after 2 weeks, when you take the membrane out, you can see the difference. The whole cornea is now no fluorescein staining. The explants are still there. The sutures come loose when you take that out, but you can see the cornea surface is completely repopulated. 6-9. We've now got about a 3-year follow-up on this patient, completely free from that cancer, because the fibrovascular panels we took away also had got CIN. There's another patient, a unilateral chemical burn without and with fluorescein, and you can see the epithelial defect is changing. Classic is the same eye. This is a classic example of a non-healing defect, a defect that does not heal or heals and breaks down repeatedly, telling you this is stem cell deficiency. So again, the acer technique was done with the same Omnigen, and you can see the end result over here. Very nice outcome with this patient. Another example, hair dye, the hydrogen peroxide injury to the eye. It started off like that, started undergoing attrition, and here the central island was completely shrinking in front of our eye over months, and then finally it came to a stage like that. Over there's some epithelial cells, but very symptomatic, very poor vision. So again, we do the acer technique, and you can see at the end of it, this is how the patient eye is. There's some reflections you're seeing. This is not scar tissue. There's a bit of scar tissue here and here, but even the tear film is very nice and normal on this patient's eye. And then one last point I make before I conclude, that when we do all of this on the eye, and this was a patient with aniridia, we've done this acer technique for him. Everything was going well till my resident brought the patient to me to say, Prof, the conjunctivalization is coming back. I said, okay, let me have a look. And I said, oh my God, this is epithelial rejection. This patient is rejecting his epithelium because this was from a living relative. So we then immediately treated aggressively with steroids. You see how everything settled. And now you've got this metaplastic epithelium, the conjunctival epithelium on the cornea. So what do? We do SSCE, we scrape it all away, that then grows back, and then it comes back here. So you can utilize, see the explants are still over there in this patient's eye. There's some stitches still there which are buried. But we have to be aware when conjunctiva is coming as part of a rejection response, or when it is coming as part of conjunctivalization following injury, and treat appropriately. If you don't take the peripheral cornea and you only take a tiny bit of limbus, then the growth on the surface is much slower. Hence, I do not take just the limbus. I also take a little bit of the peripheral cornea, and here's one example of that, very rapid growth with a oral buccal mucosal graft to sort the symblepharon before. And just to show you the donor site, we go into peripheral cornea a little bit as well. So in summary, surgical management is directed to save the eye, regenerate the ocular surface, and restore sight. Minor procedures are sequential sector conjunctival epitheliectomy and an autologous conjunctival graft, which is very useful to restore vascularization. The majors are the auto and allolimbal grafts with Acer and ex vivo expansion. Surgery should be done only when all inflammation is controlled. For allografts, whether it's cadavers or living related, you need long-term immunosuppression. We tend to use stacrolimus and then steroids or mycophenolate. And the rule is we use it for 18 months or 18 months from the last rejection episode. And everybody knows that the best experience is from autolimbal grafts. In my hands, I get 100% success rate. For a number of years, we've not lost a single eye from autolimbal grafts. But the worst is for cadaver grafts. They invariably fail given 5 or 6 or 8 years. We've had one going now for 14 years, but that was the exception, and you have to do them again. Thank you very much.
Thank you very much, Professor Dua, for this very elaborative talk about limbal stem cell reconstruction. I personally learned a lot. Thank you very much. I will just move on to our next speaker. Our next speaker is Dr. Majid Al-Kharashi. Dr. Majid Al-Kharashi is an assistant professor in King Saud University. He was also a faculty in Johns Hopkins. He obtained his residency training in ophthalmology in McGill University. Then he pursued his fellowship. I would like to welcome him to speak to us how to optimize cataract surgery with ocular surface diseases. Dr. Majid, please, the podium is yours. You are muted. You are muted, Majid.
Well, how about now?
Yes, good.
Okay. So it will be very difficult for me to give a talk after a great presentation from two great icons in ophthalmology. And I would like to thank you, Dr. Saadi, for your kind invitation. Do you see my slide, by the way?
Not yet. Yes. Yes, we do.
Okay.
Now they disappeared again. Yes, go ahead. Go ahead. Now it's okay. Yeah.
Let me just make sure it's the right one, though. Okay. Well, talking about optimizing the ocular surface prior cataract surgery. You know, cataract surgery is one of the most common and successful surgery in medicine. It offers excellent outcome with rapid recovery and low risk of complications. With this, there is more expectations from the surgeon and the patients. There are many articles that look at the incidence of ocular surface disease in patients with cataract. For example, Gupta reported that around 80% of patients presented for cataract consultation had at least one abnormal test indicative of ocular surface disease. And in the FACO study, which is a multi-center prospective study, they found that 80% of patients with cataract had some corneal staining, and around 60% had low tear breakup time. If you see a patient like this in the clinic, you need to examine the patient very well and to listen to the patient carefully, because sometimes the patient will come to you bothered from the ocular surface symptoms rather than the cataract. So if you proceed with the cataract surgery in this patient, you'll end up with unhappy patient. The other issue with ocular surface problem in patients with cataract, that you can't get an accurate intraocular calculations. Other problem is with premium IOL or multifocal IOLs. But more important than IOL calculations and multifocal lenses, that some reported patients with dry eye syndrome are at more risk of post-operative infection, and we don't want that. So we have to treat the dry eye very well. We have to treat the blepharitis, not only because the patient has dry eye, but also because cataract surgery itself might increase the symptoms of dry eye syndrome. And this is because of things that we do during the surgery or sometimes after the surgery, things that might exacerbate dry eye symptoms, like the preoperative drops that we use during the surgery. And Lee et al. Reported that patients who underwent cataract, uncomplicated cataract surgery, had some conjunctival epithelial metaplasia in the lower lid conjunctiva 3 months after the surgery. And this because of the drops that was used preoperatively and after the surgery. Other element that might exacerbate dry eye symptoms during cataract surgery is the corneal wound. Of course, when the corneal wound is large, you have more anesthesia of the cornea, and this might worsen the dry eye symptoms. However, even with a 3 millimeter clear corneal incision, there are some reports found that basal subepithelial plexus was less at 3 months after cataract surgery. Also, exposure to light can harm the conjunctival and the corneal epithelium. And the drops that we use also after the surgery might worsen the dry eye symptoms. This is an extreme example of a complication from non-steroidal anti-inflammatory drugs. Diclofenac, this patient underwent cataract surgery, presented with corneal melt at 6 weeks, and he needed the therapeutic keratoplasty. Now I'm going to mention some of the examples where we can improve the irregularity in the corneal surface to get a better outcome for cataract surgery. This is patient with cataract and pterygium. If you look at the corneal topography, you will see that there is almost 7 diopters of corneal astigmatism. This is his IOL calculation, indicating that the patient needs around 20 diopters of intraocular lens. After an amniotic membrane and pterygium excision, his pentacam improved from almost 7 diopters to 3.3 diopters, and his IOL calculation changed as well. So patients with pterygium, they will get an underestimated of the corneal power. So if you do cataract surgery with pterygium excision at the same time, you will end up with myopic surprise. This is also another example of patients with pterygium. There is almost 10 diopter of corneal astigmatism, and after the pterygium excision with the amniotic membrane, the corneal astigmatism decreased to 2.5 diopters. Another example is patient with epithelial basement membrane dystrophy. This is a professor at the university who came in for a cataract consultation, and you can see that he has a severe epithelial basement membrane dystrophy involving the visual axis. His corneal pentacam was slightly irregular. This is his IOL calculation, and this is his anterior segment OCT. And you can see quite abnormal epithelial mapping indicating irregular corneal surface. This is after epithelial debridement. the epithelial basement membrane dystrophy disappeared. And this is his corneal topography prior to the epithelial debridement. And this is his corneal topography after. And this is his anterior segment OCT. And you can see great improvement in the epithelial mapping, which indicate normalization of the corneal surface. This is his IOL calculation prior to the epithelial debridement. And you can see that that the IOL mass or IOL calculation indicates he needs around 18.5 diopter. And after the debridement, it's almost 3 diopter. So it's very important to take this in consideration prior to cataract surgery. This is a last example of a patient with the Salzmann nodules, and you can see the corneal topography is quite irregular. And this is the anterior segment OCT. You can see this in the epithelial mapping. And all of this improved after superficial keratectomy and PTK. So I usually try my best if the patient is willing to take this path of staging his cataract surgery. First is to improve the ocular surface surgically to make the cornea more regular, and then later on we can do the cataract surgery. And that's it.
Thank you very much, Dr. Majid, for this nice talk about ocular surface disease and cataract. I'd like also to thank the esteemed speakers for the nice coverage of this topic. I'd like just to start our discussion for the next 20 minutes. Dr. Donafield, I'll start with Dr. Donafield. I have a question for you regarding levetiracetam. Do you use it usually in combination with cyclosporin, or you just go with it without using the cyclosporin?
Cyclosporin and levetiracetam are both T-cell modifiers. They're both immunomodulators. So there's no data on using them together. I very rarely will use them together. Usually I'll use levetiracetam, and in a very, very rare case, I'll add cyclosporin for patients with very severe dry eye. In general, if a patient needs additional anti-inflammatory therapy, I will add a topical corticosteroid, and I find that to be a good combination.
I would like just to go again, Dr. Donafield, regarding the testing. You have elaborated about the metalloproteases, the matrix metalloprotease 9, as well as the osmolarity. So when we talk about the metalloproteases, we do have this the test available, but it's, as you have mentioned, it's only qualitative rather than quantitative. So would you depend on it more or on the osmolarity?
I prefer osmolarity. In general, I prefer osmolarity. Now, there will be a quantitative test coming out very soon, which I think may change my opinion on that. But for now, I think osmolarity for me is the test that I like most. But I would like to hear what Dr. Dua has to say about this as well. I'd like to have his input.
Yes, so thank you. Yes, so MMP-9 is an inflammatory marker, not necessarily dry eye inflammation. But any inflammation you have on the surface, you'll get these metalloproteases, you'll get the pro-inflammatory cytokines, you get the works. So if you're sure it's only dry eye, and therefore to add that objective proof that there is inflammation, it helps. But otherwise, it's not specific for dry eye, so one has to bear that in mind. And you had a very nice chart earlier, Eric showed about all the symptoms. In fact, they're all the symptoms you can get in any eye disease, which were all symptoms of dry eye. And so there was itching in there, and itching is a classic symptom also of allergic eye disease, so you'll get raised MMPs there as well. So just bear that in mind. The other thing about the way I treat dry eye, see, when I get any new patient with dry eye, I would always make a...
We don't hear you, Professor Dua.
Same when I get a new patient with dry eye, I will, when I made the clinical diagnosis, I will always treat with a preservative-free steroid. If I get a good response to the steroid, I know my cyclosporin will work. We don't have lifitegrast yet, but we will use Icurvis, which we've got. If they don't get a good response to steroids, then these drugs are not going to work, whether it's cyclosporin or lifitegrast. Once you get a good response, you have suppressed the inflammation, then you can keep it ticking over long term with these specific T cell or calcineurin inhibitors or LFA1 antagonists. My problem when I've written this and spoken about it is that the immune system is so complex and so crucial to our survival that if we depended on one molecule to stop inflammation, we would all be dead by now, because the viruses and the bacteria would have taken over. So you block one molecule, after a while, all the others will work around it and still allow inflammation to happen, because that's our body's defense. So when we deal with cyclosporin, we're dealing with one molecule that is inhibiting. Lifitegrast, one molecule is inhibiting. They're not going to work all the time. So expect failures.
That's a very good point. I also want to just maybe add a little bit to Dr. Dua brought this up, and I think it's really important. And that is that dry eye and allergy are very common comorbidities, and we see them all the time together. So many times patients who will have allergy will have a concomitant dry eye as well. And it's not readily known by many that these immunomodulators like cyclosporin and lifitegrast are very good for allergy as well. So it's something to consider, in that you can actually treat two diseases with the same drug, and the same would apply for corticosteroids as well. They treat the dry eye and the allergy very effectively. So when you think of patients with allergies, think of dry eye and vice versa.
Professor Dua, I have a question about your ACER technique, if I may. When you put your amniotic membrane, your epithelial side is up, so it's over the explant and it's under the conjunctiva, recessed conjunctiva. So do you think using it upside down, I mean epithelial side down and stromal side up, will give you a better result, that you will encourage the epithelium to grow faster, or will that affect the growth, do you think? What do you think?
I don't think it makes a difference, because where you want the cells to grow is from the explant on the cornea. Okay? Now, if you are putting an amniotic membrane, a smaller one, on the cornea to act as an inlay or a graft, then it should be epithelial side up, because you want the explant-derived epithelium to grow on it. Now, that is not ACER. ACER is the one you put on top. That one is there to either retard or to stop or to misdirect the conjunctival epithelium. So whether they grow on it or not, or they grow faster or not, or they don't go at all, it doesn't matter. Now, what we also found is, I didn't go into the details of the actual operation, but when we tuck it under the conjunctiva on the two sides, we glue it with fibrin glue. I used to put sutures long back, but we now glue it.
That's it.
And we've just sent a paper to the BJ. Only yesterday we submitted on ACER with the dry membrane and glue. The fibrin glue is a physical barrier. So if you take an explant in a petri dish and you glue it with fibrin and put another one without fibrin, the growth is always faster from the one without fibrin. Cells grow well on fibrin, but if there's a lump of fibrin around it, they will not go through it. They will wait for it to dissolve. So by sticking the sides with fibrin, we retard the conjunctiva from coming anyway. So if you don't have the amniotic membrane, but you put a lot of fibrin to glue the conjunctiva on the sclera, you will still retard the cells from coming. And yeah. So that is what you want to achieve, is don't let the conjunctiva grow on the cornea.
Good. Dr. Majid, when you did your basement membrane, if you are forced to do PTK or after the epithelial removal, for how long do you do? Do you usually wait before commencing your cataract surgery?
Well, around 3 months. Around the 3 months, or when you have reproducible pentacam and refraction.
Did you debride? How did you debride? Because we found, alcohol delamination, just like you do with LASIK or like you do for cross-linking with 20% alcohol. That is the best way to debride the epithelium for basement membrane dystrophy. And even without cataract, when you get this basement membrane dystrophy in the visual axis, you get a lot of vision degradation. And the same reason as Eric was saying, where the tear film is unstable over that area, you get negative fluorescein staining, and therefore your vision degrades. And you can be amazed how much quality of vision improvement you get by just debriding the epithelium, even without doing a cataract. I mean, if there's no cataract, then obviously you're not going to do one. So, but if you use mechanical brushing, you're creating micro scratches. And if you look at the cornea of an artificial eye where you've debrided with, after an eye bank eye, if you've debrided with a sharp instrument like a crescent blade, and you do an SEM, you will see lots of cuts and grooves in the basement membrane. But if you do with alcohol delamination, it's absolutely smooth. So that's the standard procedures now. That.
Yeah, I want to mention that Dr. Al-Qashari made a very good point about the basement membrane dystrophy. No one is going to miss the pterygium. We all know that pterygium causes decreased vision, but I see time and time again patients who come in who've had cataract surgery or considering cataract surgery where their visual disability is due to the basement membrane dystrophy. And Dr. Du and I trained with a person who really described that. Dr. Peter Leibson was the first person to describe it, and Dr. Du was absolutely right about the alcohol there. But maybe you could share with us, Dr. Al-Qashari, some of your tips for how do you look at basement membrane dystrophy? What is the best way to visualize it? Because I would think that this gets commonly missed by many doctors. Do you have some tricks on how to see them?
Yes, sure. So first, you can do a slit lamp examination with diffuse illumination. And what sometimes would be very helpful, as I showed in my picture, with retroillumination, you can see the epithelial mapping and very high illumination. The other thing you can use, as Professor Dua mentioned nicely, the negative staining of fluorescein sometimes is very helpful in detecting subtle epithelial changes in the corneal surface.
Right. I agree with you entirely. The negative fluorescein staining, and also there is an art to fluorescein staining. So you don't go with the lignoflen we used to get, the anesthetic, which is mixed with. You need 1 or 2% fluorescein, and when you put it in the eye, you'll see nothing because everything will be dark brown or black. Then you put 2 or 3 drops of saline, and you'll see nothing because everything will be green. So you do that, and then hold the lids till the tear film starts to break down. And when the tear film breaks, then you can see very clearly the delineated areas of basement membrane dystrophy which come up before the whole tear film breaks down. So, like you said quite correctly, and I agree with you, the negative fluorescein staining to me is the key to detect very subtle areas. And then, if it's obvious, then broad beam illumination will show up these if it's quite obvious, quite marked.
And I agree with all those things. And to look at the extent of the basement membrane, sometimes you'll just see minimal basement membrane changes. But what I'll do is I'll take a Q-tip, and I'll just rub the epithelium with it. If the epithelium moves easily, that means that the hemidesmosomes holding the epithelium in place are not intact. And that's how I decide exactly the extent of the epithelial debridement that I want to perform. Very, very, very common that the dystrophy will extend well beyond what you can visualize just by looking at it, as you've described. So that's a very simple test for deciding exactly how far you want to extend your debridement.
Yeah. And sometimes, go ahead, Professor.
Ask a question on that. Epithelial-based membrane dystrophy is a very well-known cause for recurrent corneal erosion syndrome, but it occurs only in about 15% of patients with EBMD get recurrent erosion spontaneously, that is, without trauma. And I think not everybody would have that loose epithelium, but you're right, many will have. And I just go by the negative fluorescein staining to demarcate the area. I've never tried that. I'll try that and see if I can move the epithelium to see the extent. But if I were to tear it, then I've started a new problem, which I might regret later.
Yeah, I was about to mention this as well. Sometimes with recurrent corneal erosion, you have to look very carefully at the corneal epithelium. Sometimes there is one cyst that's bothering the patient, and you will see the patient went to many ophthalmologists and they missed it because there is a single cyst at the junction of the upper and lower, the upper two-thirds and the lower third of the cornea. So by high magnification and careful examination, sometimes you will be able to detect it. And we do epithelial debridement, as Professor Dua described nicely. We use 20% alcohol for 20 seconds. Then we remove the whole epithelium. And in cases of recurrent corneal erosion, we go up to the limbus because we want the whole epithelium to regenerate.
Except if it's due to trauma, where the recurrent erosion is due to trauma, it's a very localized area. If it's a base membrane dystrophy, then you will find this extensive. But here's another little tip, which I think you mentioned it, but just to re-emphasize, there are tiny intraepithelial microcysts sometimes, or sometimes some subepithelial accumulation of debris. So here's the trick. When you do your negative fluorescein stain, you're not even at your tear film breakup time. If the tear film breaks up at the same spot repeatedly, that is your culprit spot. Otherwise, tear film breakup is random, the normal tear film breakup. But you blink and you find that spot. Then you blink again, it's the same spot that's coming up repeatedly. And there may be other bits, but there's one spot. That is the area where you're going to experience the symptoms. So look out for that, the consistency of breakup at one spot.
Good. Let me move just to some questions I have received. About a few questions were directed to Professor Donafield regarding leafy-grass. Are you using it for any other inflammation? Do you use it post-LASIK? Those were the questions about leafy-grass.
Leafy-grass works on the T lymphocyte and inflammation after cataract surgery and after LASIK is predominantly not T lymphocyte, it's predominantly neutrophil and macrophage. So it really doesn't have much of an effect on those diseases. It will look on other inflammatory diseases, and I have used it, for example, on patients who have had corneal transplants and I want to prevent rejection. Just as I've used cyclosporin in the same setting. It inhibits the ability of T lymphocytes to bind. I've used it for allergy as well. So those are two other places where I found it very useful. We described the use of cyclosporin for corneal transplant rejection a number of years ago. And for patients who are steroid responders, where you have the issue with the intraocular pressure going up very high, sometimes immunomodulators like leafy-grass or cyclosporin are all that's available for these patients, unless you want to deal with the glaucoma sequelae.
Thank you very much. A question to all the speakers: would you stop cyclosporin before cataract? If a patient is on cyclosporin for dry eye, or will you continue it before that? That's a question from the audience. I'll start with Dr. Donafield.
Yeah, there's no reason to stop these medications. Many times I won't have the patient take it the day of surgery just because the lipid in the cyclosporin tends to be a little bit adherent, but I very commonly will continue the medication the first post-operative day.
Thank you. Majid?
Yeah, no, I will continue using the cyclosporin. You know, the cataract surgery by itself will exacerbate the inflammation and the dry eye syndrome. So controlling the inflammation with cyclosporin, I think it's a good idea.
Thank you. Professor Dua, would you have a different opinion?
I do actually, because I would be using steroids post-cataract. We're not only controlling surface inflammation, we're going to use intraocular inflammation as well. And nothing works as good as steroids. The problem with steroids is they have lots of side effects. So we can't, and there's no point using cyclosporin and steroids. Now, in my standard regime in our hospital, we would use steroids for at least 3 weeks post-op cataract, 4 times a day. We have a standard hospital preparation of a dexamethasone prep with antibiotic called Maxitrol. So if you're using dexamethasone, you don't need to use cyclosporin at the same time. But because dexamethasone, all that cyclosporin does and more.
But
once you're going to stop it, you might want to overlap the two before you stop dexa and then you start with your cyclosporin again.
So I wanted to play the devil advocate asking that question exactly. So we need time for the cyclosporin to kick in. And if we use that for 3 weeks, why shall I stop? Why don't I overlap them so I can stop the steroid earlier and without the manifestation of dry eye disease? I get your point very well, but
feeling cyclosporin will not control the intraocular inflammation.
No, I'm talking about the dry eye. Patient with a dry eye on cyclosporin, I'm doing cataract surgery.
Absolutely, but that's exactly what I'm saying. After cataract surgery, you get intraocular inflammation. You get cells in the AC, you get a bit of iritis. That's why we use steroids after cataract surgery to control that. But they have then the spin-out effect of also controlling the surface, because if there's inflammation on the surface, which is why you're using your cyclosporin.
Yeah, I think you're both essentially right about this. Dr. Dua is absolutely right that steroids are much more potent and have effect on intraocular inflammation, and they control the inflammatory pathways beyond T lymphocytes. But Dr. Saadi, you were also correct in that if a patient stops their immunomodulators, with fitograft or cyclosporin, the corticosteroids do not have any effect on allowing the cyclosporin to be restarted again. So you have to understand that cyclosporin takes about 90 days to achieve the maximum effect. The fitografts may take 2 weeks or 4 weeks, which is why I prefer it. But if you stop the cyclosporin while you're on the corticosteroids, you're going to go back and start it later on. The patient most likely is going to have an overlap period of time where the cyclosporin has to start working again, and they may have dry symptoms that could be avoided if they stayed on the cyclosporin in the immediate postoperative period.
Professor Dua, I have a question about the living donor limbal stem cells transplant. In some report, why do you think after 18 months we can stop the immune suppression for patients who are receiving from a living donor or who had successful surgery? Then usually patients, they do not reject. What's happening? Any explanation for that?
Yeah, it's a very interesting question, and the explanation is hypothetical. If you look at the donor-derived DNA on the surface of the eye of the recipient, after 20 weeks, sometimes they find no evidence of that. But there are some conflicting reports, and some reports say there isn't. The earlier ones said there isn't. So if all the donor, say you got a male to a female transplant, your Y chromosome bearing cells are gone, but the surface is still okay. So how did that happen? So the theory is that once you restore the niche or the surface environment, then you have bone marrow derived stem cells which are constantly circulating. They home into the surface of the eye and they start producing the trans-differentiating epithelium. So then the host cells have effectively replaced that. So that is probably the reason why. And the 18 months, what we chose this is because we were immunosuppressing patients for a year. And it was just an arbitrary figure we picked from experience. And we were giving them oral, which is systemic immunosuppression for a year, with at least a steroid and a single immunosuppressive agent or a combination. And that's a very interesting point, again, Professor Donenfeld made about using these immunosuppressants for graft rejection if they're steroid responders topically. We have also added to our bag of tricks the tacrolimus, which is protopic skin ointment. In skin ointment, it comes in 0.03 and 0.1%. So the 0.03%, and it is interesting how sometimes these things work out by accident. We used to ask the patient to put a bit in the eye. You know, it's not meant for the eye. It's a lot of the things we are telling you are off-label because lifitegrast is only licensed for dry eye. It's not for anything else. Cyclosporin is only licensed for dry eye. Now it is also for vernal catarrh, but it's not for AKC. I use it a lot in atopic keratoconjunctivitis as well, and in graft rejection, and in graft versus host disease, and in ocular cicatricial pemphigoid. So I've used it for many. We got a paper just come back for major revision with BJO of just under 500 patients with real life experience using cyclosporin, the Icurvis drops. So the reason why we changed from 12 months to 18 months was we were getting, as soon as we stopped the systemic immunosuppression, we were getting rejection in patients, which worried us. So we said, well, we have to extend this. And what we found is by extending it for 18 months, then the amount of rejection on stopping was less than it was at 1 year. So that is the reason. It's an arbitrary figure. However, for corneal grafts, not for stem cells, for corneal grafts, completely different story, because the donor epithelium is completely replaced by host epithelium by 1 year. And that's why I think the risk of rejection of donor grafts is highest within 1 year of transplantation, and then it drops. It never goes away, it drops. So if the donor epithelium is completely replaced by the host, then you can stop the immunosuppression, tailor it quicker than if it's still there. So sometimes, you find diabetic donors, the whole epithelium is gone. And then right from day one, it is recovered by the recipient epithelium. Then the antigen load and the risk of rejection becomes less, because if there's only endothelium, it's relatively less, as we've seen with our D-sex and our D-mix.
Thank you very much. I'd like really to thank you all. For the sake of time, I think we will just conclude. Once more, I'd like really to thank the elite speaker for the nice talks as well as nice discussion, very enriching. Also, I'd like to thank the Emirates Society for organizing this, and thanking them for assigning me to do that. I'd like to thank Novartis for supporting the event and supporting the society. Thank you all, and thanks for our audience for being there, for asking questions. We hope that was very satisfying, and I wish those who are on the before Greenwich a very nice evening, and sleep well. And those who are to the west of Greenwich, we wish you a very productive day, Dr. Donenfeld. Have a good night and a good day, Dr. Donenfeld. Thank you very much.
Thank you.
Thank you for the invitation.